Welcome and good afternoon. I'm Brian Laux, Program Coordinator for Cardiac and Pulmonary Rehab at the University of Maryland, Charles Regional Medical Center. I will be your moderator today. In today's webinar, we'll be discussing women's health and addressing those topics that mean the most to women of all ages in Southern Maryland. With so much information to learn, it can be overwhelming on where to start, but today, Dr. Lauren Outlaw, a board-certified obstetrician gynecologist at University of Maryland, Charles Regional Medical Group, Women's Health, and Dr. Briana Walton, the medical director of female pelvic medicine at University of Maryland, Capital Region Health Medical Group, Urogynecology, have teamed up to be your guide. Before we get started, we have a few housekeeping items to address. If you experience technical difficulties, post your issue in the Q&A panel found in the bottom right of your screen. This event is being recorded, so you can view it at a later time as well. This is an interactive webinar, and we want your participation. We encourage you to submit written questions at any time during the presentation using the Q&A panel in the bottom right of your screen. We will address questions during the Q&A session at the end. Please don't hesitate to ask a question. Questions will be shared anonymously, and we are all here to learn right alongside you. To begin, we're going to conduct an anonymous poll. Have you put off seeing a healthcare provider during the COVID-19 pandemic? We will revisit this question at the end of the webinar. Now let's start the conversation. Our first guest speaker, Dr. Lauren Outlaw, is a board-certified OBGYN. Originally from Indiana, Dr. Outlaw has extensive experience in international mission work and found that obstetrics and gynecology combine the things that were most enjoyable about medicine, the continuity of care and surgery. This gave her the opportunity to make a positive impact on women both locally and internationally. She spent the 4th year of her residency serving Guatemalan women and later in several additional countries through Doctors Without Borders. Dr. Outlaw's healthcare philosophy is that the relationship between a physician and a patient is one of the most important an individual will have. She believes that they must work together in order to optimize the health of the patient. Thank you for joining us today, Dr. Outlaw. So Dr. Outlaw, our first question today is, you're an OBGYN. Does that mean that women can only see you for childbearing reasons?
No, so that's probably a common misconception. A lot of women, after they finish having their children, stop being seen by their OBGYN. But no, we take care of women from ages to late adolescence, or like mid-teens, all the way up to post-menopausal women, so 60 and above. I have some patients that are in their 70s or 80s that come to see me. So we do well women checks each year, similar to somebody who would go see their primary care doctor every year. So you don't have to be pregnant just to come to our office.
Great, thank you. And to follow up on that answer, at what age can care with an OBGYN be established?
So it really depends on what's going on in your life. A lot of women, don't have any problems, may or may not be sexually active. And if you're not having any problems, you have a primary care doctor who can take care of you, or a pediatrician. I would say normally, early 2020, 21 would be a good time at minimal to start. That's where at this point in time, we're starting pap smears on women. However, if you have GYN problems earlier, feel free to come in earlier. I've seen patients as young as 12 or 11 in my practice. So really, it just kind of depends on what the issue is, and if your pediatrician isn't comfortable taking care of that issue when you're an early adolescent, then a lot of times they'll refer you to a gynecologist. I have a lot of teenagers that I see as well.
Great. So it sounds like it's more of when you start having some of those health concerns and not as much as the age.
Correct. That pertain to your female organs. Yes.
Okay, great. So if someone has a primary care provider, Do they need an OBGYN? And if so, why?
Well, I see it like this. It depends on your primary care provider. You know, a lot of women have primary care physicians who are more than capable and comfortable taking care of all of their issues. So if your primary care provider is comfortable doing your annual breast exam, if they're comfortable doing your annual pelvic exam, so screening you for, for cervical cancer every year, meaning taking a look with the speculum inside of your vagina as well as feeling, then you may not necessarily need to see a gynecologist every year. Um, you know, more and more, a lot of primary care doctors are not comfortable doing that. So, if that's the case, then yes, we would want you to come see us in our office. But I think you should do what's most convenient for you. What I care most about is not who does your exam, but is that you're getting that exam every year. So if you have a primary care physician who's comfortable to evaluate you each year, then I would prefer you to do that as opposed to not see anyone. But if not, then yes, we would want you to come see a gynecologist.
Great. That's a very good answer. What are some of the most common conditions that you see women for?
So outside of the normal annual exam, I see women with pelvic pain, abnormal bleeding, heavy periods. I see women after pregnancy. I see women, after they've gone through menopausal bleeding. I see women with abnormal vaginal discharge, women who have concerns about breast masses. So a lot of times we'll do the preliminary workup for them. I see women for abdominal pain, for hormonal issues. So there's a whole slew, painful periods. There's a lot of things that we see women for. Just birth control as well. A lot of times that's what some of our adolescents come into to start birth control. So those are just a few things.
Very good. So what services and screenings outside of those related to pregnancy do OBGYNs provide?
So we screen you for breast cancer every year. So that's with your annual breast exam. We screen you for cervical cancer. We screen women for sexually transmitted diseases. Just as some primary care doctors will do everything for, including the female exam for some of their female patients. Sometimes I do more extensive exams for some of my female patients who don't have primary care doctors. So occasionally I'll screen the people for high cholesterol, thyroid disease, diabetes. Now, obviously, if some of these things start to come back abnormal, then I'll have to send you to a specialist or a primary care physician who treats these more regularly than I do. I normally take care of these problems in pregnancy, but not necessarily outside of pregnancy. So really, it's important to become familiar with your patient, know their medical background, and kind of know where they're getting their care at, because that is more so what helps determine what extra lab work or exams or things they may need necessary. So sometimes we help coordinate some of that care for patients as well.
So just to touch on what you had mentioned a second ago, you said with some patients you kind of take almost an overall approach in some ways.
Correct.
As part of that overall approach, do OBGYNs also address issues of mental health? And if so, what kind?
Yeah, so actually that's something I should have mentioned as well. We screen for depression and anxiety. Some OBGYNs are going to be a little bit more comfortable treating patients with that. We definitely treat it in pregnancy. A lot of times I believe sometimes that it's important to have the best in certain areas. So if you have depression or you have anxiety, I'm more than happy to start medications, but I also think it's important to have at least a therapist on board to help deal with navigating those medical problems, because depression and anxiety is a medical problem just like high blood pressure or diabetes, and it's something that should be taken seriously because it affects the overall health and care of the individual you're taking care of.
Yeah, so really emphasizing that relationship with the patient, kind of figuring out what the patient needs whether that's in your area of expertise or not. And then if it's not, possibly handling it, but then also referring them to the correct person that can help them with that.
Yes, that is exactly correct.
Okay. So, and finally, what can someone expect if they come to see you for care?
So, the first thing that you can expect is a check-in process that may even at all offices. So just make sure you have your insurance card and identification for that. Then we check a weight on most people. We will check a blood pressure, and then your physician or myself would have a conversation with you to see what it is that brings you in to see me today. And then most women will end up with an exam in some form afterwards, depending on if you're coming for just an annual. I'm going to feel on your neck. I will listen to your heart and lungs. I do a breast exam, abdominal exam, so I feel on your stomach, and then we'll do your in with your pelvic exam. And then I normally kind of like to go through everything we talked about and what our plan is and when you would follow up. Some will screen you by taking a urine sample when you come in as well. So really it depends on what you're coming in for. And not every patient comes to the gynecologist needs a pelvic exam. If you were just coming to start birth control and you'd been seen within the last couple of months, then it might just be that we're having a conversation, or some women come to talk about planning to get pregnant. And in those cases, a lot of times, if you're not having any issues, that's kind of just a counseling conversation session. But the majority of my patients will have a pelvic exam in some form when they come in.
And so the exam that you were just mentioning, the pelvic exam, is that a routine practice with your visits, or is that more of for a first initial visit?
Well, it depends on the age as well. So if I have a young adolescent who's not sexually active and doesn't have any pelvic organ complaints, then she may not necessarily need a pelvic exam at that point in time. So I won't say it's routine. It's more so the exam outside of the well woman annual exam is very much problem focused, like it would be if you went to any other physician for evaluation. So if you went to a cardiologist, they would listen to your heart and maybe do an EKG in some form for a lot of their patients. So I specialize in the pelvic organs. So does that kind of answer the question that you're asking?
Yes, it did. Thank you very much. So again, thank you for all of your expertise. That was very helpful. Now let's turn to our next guest speaker, Dr. Briana Walton. Dr. Walton, you and Dr. Outlaw seem to have similar paths over the last 20 years, as you have provided medical support for women abroad as well. Specifically, you were dealing with a group of patients who suffered obstetrical trauma, as well as women who needed reconstruction after horrific events like genocide and female genital mutilation. I'm sure many of these experiences inform your practice here in the United States to provide expertise in gynecology, female urology, and a focus on the treatment of pelvic floor disorders. Although women in the US and abroad may have different reasons for the intimate healthcare topics, they are similar in that women suffer in silence because they are too embarrassed to talk about these problems, such as incompetence or prolapse. As Director of Female Pelvic Medicine and Surgery, we're glad to have you in our system to bring these vital services to women in our communities and beyond. Dr. Walton, thank you for joining us today.
Brian, thank you for having me. I'm excited to talk to you all today.
Great. So could you please begin by explaining to us what urogynecology is and what a urogynecologist does?
Good question. It's funny. A lot of times people will make assumptions about what urogynecology is, and even some providers are a little confused at what it is I do. But I like to think of it as a combination of female urology and gynecology with some colorectal conditions that we manage. Most of my practice is tailored around pelvic floor disorders, which we're going to get into a little bit later, I think.
Okay. So thank you for kind of giving us the background of that and kind of distinguishing between, what all of that is. Now that we kind of have a better understanding of that, what conditions does a urogynecologist treat?
So just along those same lines, if you think about the pelvis and in the organs that live in the pelvis, you have your urinary system, you have your pelvic organs, your female genitalia, as well as your rectum. And so we manage a lot of the conditions sort of below the belt. That's probably the easiest way to describe it. I like to just say it more as the 3 B's: bladder problems, bowel problems, and anything that bulges outside of the vagina.
That's a good analogy to remember all of that by. And you had mentioned the pelvic floor earlier. So our next question does involve the pelvic floor. What is the pelvic floor, and why is it so important to women's health and quality of life?
Sure. So it is, you know, pelvic floor has a sort of a mystique about it. Like, what is it exactly? From the vantage point of a urogynecologist, we really consider it a sort of the compilation of everything within the pelvis: muscles, nerves, tissue, organs, and how they come together, one, to support the organs and help them function. The problem with women who have these disorders, as you mentioned earlier, many of them suffer in silence. They're too embarrassed to talk about bowel issues. So, for example, if a woman has bowel incontinence, she can't control her gas or she can't control her stool. That's not something that she sometimes is even comfortable talking about with her primary care physician. If a woman has leakage or incontinence of their urinary tract, or they have recurrent urinary tract infections, those are things that we help to manage. And we know that from a quality of life standpoint, as Dr. Outlaw mentioned, we see a significant impact on depression, particularly in our elderly population. But it's not just skewed to that population. Our younger patients as well have, you know, that sort of I don't want to talk about it, I'm embarrassed about it. And then when I do, what can I do about it that won't necessarily put me in a place where I can't function, especially for our young people. So a lot of these disorders, I think, are taboo for many women to talk about, but hopefully with Dr. Outlaw screening patients, she'll even, you know, discern patients who have sexual dysfunction, which is another sort of area that we look into and manage too, particularly when it's associated with the bulges, with the herniations of the pelvis.
Yeah, so I think kind of touching on what Dr. Outlaw had mentioned earlier, that relationship with the patient, especially with this particular topic, seems like it'd be very important.
Yes, yes, you're right.
So that way, you know, people could open up a little bit more and maybe share the experiences for the health reasons that they're having at that time. So when would someone go to a urogynecologist instead of a standard urologist, gynecologist, or even a practitioner who deals with bowel problems?
Sure, sure. I think there's always the concern is either or, and sometimes it's in addition to. We try to streamline our referral process so that a patient doesn't have to see multiple people and then deliberate over those embarrassing topics multiple times. But when a patient is seeing their primary care and or their OBGYN, and there are conditions that discipline is not comfortable dealing with, they would tend to refer to us. If a patient has kidney stones or if they have cancer of the urinary tract, that's not my field. Again, if you think about everything below the hips is pretty much my territory. And from the urinary standpoint, anything above the hips is a urologist. That's probably a safe way to manage it. Very often, if I'm in the operating room, I will operate with my OBGYN colleagues if a patient desires or the doctor desires it. So it's much more of a complementary relationship as opposed to competitive.
Okay, great. Thank you for clarifying that.
Sure.
And lastly, what can someone expect when they come to see you for care?
So, from an expectation standpoint, I hope that they walk away. That's always my goal personally, for them to walk away saying, I learned so much about myself and some degree of empowerment. Much like Dr. Outlaw, we're going to go through the standard processes with the check-in and doing the exam. But my exam is going to be sort of laser-like focused on the pelvic floor. And in that, I'm looking at neurologic function, I'm looking at muscular function, which, some patients are surprised that I can figure out if they have chronic back pain or back problems because of the relationship with, as I like to use this analogy, the core, the floor, and the back door. So it helps me to sort of inform the patient and say, hey, this is you're one person, you've got a lot of people to manage your issues. I'm doing part of it, but I want you to know I'm collaborating with your providers in order to take care of this. And then the final is to really just look at the organs themselves, the tissue, to see, are they postmenopausal or premenopausal? Is there any type of bulge? Is there any condition or mass there that might be lending to those symptoms that the patients are having? So a very comprehensive pelvic floor examination along with whatever else is necessary to supplement the diagnosis.
Great. And that it sounds like that pelvic floor region is such an important area in that pelvis area due to all of the things that it contributes to. So,
yeah, I think what we are starting to understand more of, particularly again, since so many patients have orthopedic issues, right? How many patients over the age of 50 complain of knee pain or back pain, and as their gait and their posture changes, it's the pelvis that has to bear that sort of weight and difference in motion and ergonomics. And so there's this sort of complementary thing. And in fact, for many of our patients, one of the key risk factors is hip fractures and falls because people getting up going to the bathroom at night. So it is not something that is like just, a subspecialty where it's just, well, I don't have to deal with this. It is an important area where we try to make sure women are informed and empower them with the options to manage their care.
and just to follow up on that, it also sounds like um, that by correcting some of these issues, it could lead to better health in other areas as well.
Yes, yes. Well, it's so funny because, most of my patients who end up going to surgery, it's an elective surgery, meaning it's not cosmetic, but it's something that is you're not going to die if you don't have this done. But I can influence them by saying, I'm not doing your surgery until you stop smoking, or I'd like you to lose 30 pounds before the surgery. So that just improves their overall health condition. Not that I'm trying to judge or shame, it just will want to put them in a better position so that they get a better outcome.
That's a very good point. So, thank you again for educating us on such an
Sure.
intimate topic. And I know some are probably a little too embarrassed to share about that. So, thank you.
Thank you. Thank you.
So now let's turn our conversation to the Q&A. We'll continue the conversation by taking some questions audience members are submitting. Please remember your questions will be shared anonymously. No question is too much, and chances are, if you have a question, someone else has the same question. So one of the questions that we got from the audience today, and I'll throw it out there, and then either Dr. Walton or Dr. Outlaw, either one of you can chime in. The first question is it necessary for a woman postmenopausal without a uterus to see a gynecologist?
Sorry, I had to unmute myself. So I feel that it is. One, as as it was previously kind of touched on, we do more than just evaluate the uterus. And so we also evaluate the vagina. A lot of women who are postmenopausal may start to suffer from vaginal dryness, vaginal irritation. We take a look at the outside of the vagina in good detail. Sometimes women will start to have changes to the skin on the area that's called the vulva, which is the outside of your vagina. And so we would pick up on that when we do the exam to take a look. And then we also do the breast exam as well. So again, if you're not getting somebody to look at your whole body somewhere, then yes, I do think that you should still see a gynecologist. And we also will pick up on some of those symptoms that women start to have as they get older, such as loss of urine, loss of stool or gas, or bulges, especially in women who have had children in the past, and some of those pelvic floor options. So yes.
Brian, I'll also
Sure.
just add on, thanks for that, Dr. Outlaw, too, that a woman who's had a hysterectomy will sometimes assume there's nothing else that could happen down there. So that's a fallacy, and it is very helpful for particularly a gynecologist when they're screening. They're going to look a little bit differently, perhaps, than someone else who's not trained in obstetrics and gynecology or even urology. Particularly when it comes to bulges, because they can be fairly subtle on the inside. So I sometimes will refer to, well, you have an innie and not an outie when it comes to the bulge. And you're not going to know this unless we do a partial exam to hold down the pelvic floor wall or the vagina in order to see what else could be happening at the same time. I think women also, if they're not getting the answer that they want, they have a symptom and they feel like I didn't really get it addressed the way I needed to, then just ask for another consultation with one of the providers. Sometimes you just need a fresh set of eyes.
Yeah, I think being the best, being your advocate for your health is probably the best thing. So fresh set of eyes can't hurt anything, right? So our next question, what physician would best be seen for perineal pain that is not pelvic pain?
So I'll start with that one. I see a lot of patients with pelvic pain and specifically perineal pain, but the question is, what is it and where is it coming from? Is it muscular? Is it related to a neurologic condition? Is there some sort of prolapse that is underlying? So from the standpoint of being able to screen some of the common etiologies for perineal pain, I'm certainly am happy to see a patient for those conditions. But then I think the next step is that we're pretty good at triaging and saying, yeah, I'm not the right person for you, but perhaps a colorectal person or someone else who is a specialist in neurourology. So we can sort of navigate that landscape with the patient to find the right provider.
And now there's even some specialists who solely look at chronic pelvic pain, or who specialize in that. And so that would take that also, they would also evaluate or treat patients who have pain. And like Dr. Walton said, it depends on kind of where it started and what's possibly the cause of that pain. And then it's becoming more of a specialty now is pelvic floor physical therapy, who I've had patients that they've done wonders for. So, definitely seeing somebody to help screen and determine, we may not be the place that you end at, but we might be the place that you start at to help start you on your journey to recovery.
That's a really good point. Thank you. So our next question, I guess we'll ask Dr. Outlaw, and then if Dr. Walton has anything, she can add to it at the end. Do waist trainers affect the woman's reproductive organs in the future?
Like wearing it for like exercise or to help shrink the waist?
I guess just using them?
It shouldn't have any effect on your pelvic organs. There are a lot of things that occur between the outside of your body, the skin. there's fat, there's muscle, there's a layer called fascia. So there's a lot of things that kind of protect the organs that are inside, as well as your uterus and your ovaries and your fallopian tubes kind of are protected by the hip bones of your pelvis, and as Dr. Walton touched on, the pelvic floor muscles as well. So there's a lot of protection around your pelvic organs, but no, it shouldn't harm them.
Okay. Well, I'm going to chime in.
Sure.
And I agree fully. I would just say there are waist trainers and then there are waist trainers. And there are people who are really trying to cinch everything in to achieve a certain look. And with the increases in intra-abdominal pressure in a patient who already is a little bit vulnerable to pelvic organ prolapse, I would be somewhat concerned about that. And in particular for women who they're trying to correct a rectus diastasis. So a lot of women, after they've had a pregnancy, the six-pack muscles in the midline will separate and they have a gap there. And the waist trainers are good about closing that gap off, but that sort of stretchiness can also indicate that you're stretchy in other places. And so again, just being a little more careful about screening yourself to make sure that you don't have any concurrent conditions.
So our next question is, whom should I see first for stress incontinence post-delivery? So Dr. Outlaw, if you'd like to answer that.
I don't know who's going to take it. So yeah, normally, initially you would have a follow-up appointment with your OBGYN, which I think a lot of patients say, oh, I have my baby, I'm doing fine, I don't need to go back. And then maybe a couple weeks or even a couple months afterwards, they start to have some of these symptoms. So it is important to follow up for your postpartum visit. And then I always have people come back in a couple months for another annual exam. But you would normally probably see your gynecologist first or your obstetrician first, just because you're going to see them initially. And there are some things that we can try to do prior to sending you to the urogynecologist to help with the stress incontinence. I think as I've been practicing longer and longer, the biggest thing I noticed is it's not something you want to wait till after you have the baby to start doing. There's some exercises that we can do while you're pregnant to help strengthen those pelvic floor muscles, to maybe help lower the intensity of some of the issues you have, or, you know, eliminate you from having them. And a lot of times, if you do that before, or if we start early enough after you have the delivery, it will be a problem that's kind of easily reversible. Now, for people who have this problem and it's continuing, then definitely, yes, I would refer you to a urogynecologist for further evaluation if necessary, as well as I tell my patients, I'm not here to, you know, I have no ego in this. I don't mind, even if you want a second set of eyes or a second opinion, sending you to the urogynecologist, because, you know, we should all work together to help make your journey with your healthcare, you know, good.
Yeah. And I think most, so the studies say that about 2/3 of women who have leakage immediately after their delivery, most of that 2/3 will correct within the first 6 weeks. But if it's persistent and it's bothersome for a patient, like Dr. Outlaw mentioned, doing pelvic floor exercises with or without a trainer is very helpful to sort of regain some of that pelvic floor tone and a pelvic floor muscle mass. Now, a lot of times incontinence is not just a muscle issue, it's a tissue issue. And so you can go to the physical therapist, or you can do some of the exercises and still not see some differences. So in that case, that's when it becomes important. If you've sort of not done well with your traditional sort of map of, I'll see this, I'll do those exercises. If the exercises are not working, see a therapist. Because most women, honestly, they don't do the exercises correctly. So they need a little bit of help to say, hey, I'm your personal trainer for a few minutes. We're going to teach you how to do Kegels properly.
Yeah, so this is a really great answer. Thank you. So I'll probably direct this next question to Dr. Walton, since it includes one of those 3 Bs that she discussed. When a woman first starts having a bladder issue, such as urine release changing or feeling as if the bladder is not empty, but the woman does not have a UTI or an infection, what can be the cause, or should they see a gynecologist or a urogynecologist?
Mm-hmm. That's a great question, and whoever asked it, good for you, because there are some subtleties that happen that I think as women we don't always pick up on. Like, for example, to sort of supplement potentially what this person is talking about, you have to sit down and do a bunch of toilet hygiene, map it out with toilet paper so that you don't spray urine down your leg, or your position has to be different when you're voiding. That can suggest sometimes that there is a change in the anatomy and that the urine has to go through an altered flow course. So that I would suggest either one of us to be the person that screens to say, is that possibly a change? When one thing, and I think that that person also indicated, is there's a flow pattern with urination that we will often say, you'll hear people say, well, to do Kegels, stop the flow of urine and then see if you can restart it again. Then you're using the right muscles. That is correct, but we don't recommend doing that over and over again, because you're training the bladder to do something that it's not used to. The bladder is supposed to fill up completely, and then when it's time, squeeze in order to empty fully. And if you're constantly stopping and starting the stream, stopping and starting the stream, the bladder is going to get confused and you may not empty completely. So just a little shout out about doing Kegels in the right way, and not always using that mechanism when you're voiding to identify the muscles.
Okay, great. Thank you. So our next question will maybe direct towards Dr. Outlaw. Can you explain bladder cancer?
Actually, Dr. Walton probably would be better.
Or if Dr. Walton wants to take it, that's fine as well.
I can take that one. So just in terms of the explanation of bladder cancers are not very common. I don't deal with bladder cancer, but I do screen for bladder cancer. It is one of the more, should we say, friendly cancers, because it shows up usually with some sort of blood in the urine. So Dr. Outlaw, during her intake visit, she does a screening UA to look for blood in the urine. Your primary care does a UA, and if you have serial blood in the urine, at that point in time, you would be referred to myself or to a urologist to work up hematuria, or blood in the urine. From there, we potentially would do an exam called a cystoscopy, where you take a small camera and a scope and look inside of the urethra and the bladder to look at whether or not there's a mass there. Bladder cancers are much more common in patients who have a smoking history and in patients who have some occupational exposures that are honestly quite rare now.
Okay. We have another question here from the audience. What may be the cause of uterus throbbing?
Sorry, I had to turn mute. So it can be a lot of things. One, it could be just normal cramps that you have with your period. So the uterus is nothing but a muscle that is made to house a baby when you get pregnant. And the process of us having a menstrual cycle or a period each month, or every, we'll say 3 to 6 weeks, is the shedding of the inner lining that's not part of that muscle. But in order to do that, your uterus, that muscle has to contract, just like you could, I don't know if you guys can see my big bicep here, but contracting the muscle of your arm. So it kind of has to squeeze. And so that's going to cause some discomfort. In some women, not all women have this discomfort. Sometimes you can have conditions where that lining that sheds some of those cells are small parts of it can make its way into the muscle part where it's not supposed to be, and that can cause you to have pain. So normally when women come in with pelvic pain or throbbing of their uterus, you would start off with an exam because your pelvis is nothing but a bowl full of organs. Think of it kind of like a bowl of spaghetti with meatballs and whatever else you like to put in your spaghetti, but it's all just thrown in there. Then, sometimes things that are in the same area, one assumes that it's coming from the uterus, but it could be coming from the ovaries. It could be coming from your intestines. It could be musculoskeletal. I have a lot of women who think they're having ovarian pain, but when you actually take the time to do a thorough pelvic exam, their pain that I'm able to reproduce comes from the muscles of the pelvic floor. So, there could be a lot of causes for the discomfort. So the first thing is that you need an exam to be evaluated to kind of differentiate what it is that you're actually feeling and when is it occurring, how often, how long does it last, does it travel anywhere, and then doing an exam to see, is this what is what I'm touching right now where you're having the pain, and that kind of starts to help the workout to figure out what's going on.
Okay, so it sounds like it could come from a number of different things, and having that exam will really help you pinpoint what's causing that throbbing. So our next question is, should a woman in their late 60s discontinue pap smear tests? Either of you can take that.
I can take it. So
okay.
It's not as simple as a yes or no. As we've stated several times and probably overstated, we do still think even after you get to your late 60s that you still need to come in to see a gynecologist because there are other things that can occur. They just updated the guidelines. The nice thing about being an obstetrician gynecologist is we kind of have an overhead college that gives us guidelines of things we should do. And so the age is 65 now, as determined by Obstetrics and Gynecology College, as well as the American Cancer Society. Thinks if you have had the last couple of pap smears have been normal, you don't have any history of precancerous lesions that are in the high grade or severe, the step right before cancer, that yes, if you've had a fairly normal pap smear history after 65, you can stop getting them if you've had some serial ones prior to that. Now, if you're someone who had their last baby and then you haven't been seen by a doctor for 30 years and then you're 65, then maybe we need to follow you a little bit longer to have a couple normal ones before we stop doing them. But also, if you get to be 70 or 72 and you show up one day and you have bleeding that you haven't had since you went through menopause in the 50s, well, part of your workup might include doing a pap smear at that point in time. So it's not as black and white as saying, yes, you get to this point, you never have to have it again. Now, for women who have never had an abnormal pap smear, who have had a hysterectomy where they take your cervix, because a lot of women have hysterectomies, and unfortunately, I think sometimes, and I am at fault of this as well, you just, don't ask enough questions sometimes. So like we talked about earlier, you have to be an advocate for yourself, for your physicians. But we assume that things are done that may not necessarily be done. So one, it's my job to make sure that I educate you as far as what I'm doing at your exam and what exactly is being done for you when you have surgery. But there are some women who assume their cervix is gone, and then I take a look and I'm like, oh, no, they left it behind. So if you've had your cervix removed with your hysterectomy, and you've never had an abnormal pap smear or haven't had an abnormal one in several years, then yes, you may be able to stop getting pap smears, but you still need your vagina looked at, and you still need to see a gynecologist to pick up on some of those things that we've talked about already.
Great,
Brian,
thank you.
I just want to throw out there
Sure.
that, we don't want to exclude our newly sexually active seniors.
Yes.
Some people have resumed sexual function after partner passes away and they meet new partner. And so that is potentially a risk factor for the transmission of HPV and therefore cervical cancer. So that's another scenario where you have to sort of be honest with your provider so that they can screen you appropriately.
That's a great point. Thank you, Dr. Walton. Our next question is, are there any negative side effects for long-term use of a menstrual cup? And it looks like Dr. Outlaw might be taking that one.
Oh, okay.
Walton, that's fine.
I couldn't hear you. Well, I'll just chime in. I don't know a lot about menstrual cups, but we use pessaries a lot, which are similar materials that you place inside of the vagina. And so most of the materials are inactive or inert. When it comes to vaginal tissues, there can be more inflammation and infection associated with it. But there's no long-term data that I've ever seen that it is associated with anything negative. But we have to remember menstrual cups haven't been around for 50 years. And so we do need to continue to monitor, make sure that there's no issues with it. I think as long as you're getting your routine screenings, there's really, that's just, you're going to just watch it. Surveillance is key.
Only thing I would add to that too is that, I think it's one thing to use it for the week or 5 or 3 days while you're on your period. And, I assume most people, because again, this is something that people have started using recently, are taking them out to empty them out and make sure they're clean and things like that. So you want to make sure you maintain good hygiene of the menstrual cups. But that's not something I would necessarily say that you need to wear every single day, 365 days a year. And just like with the pessary, you would want to make sure you're cleaning it regularly.
Okay, thank you. So we have one final audience question here. And maybe Dr. Outlaw, you can touch on this as well. Can postpartum that is unaddressed cause future problems?
Postpartum what? Postpartum?
It just says postpartum that's not addressed. Can that cause future problems?
So I'm going to take it from the standpoint that you had a postpartum exam that you maybe missed. Obviously, if there's some diseases that develop after you have your baby, so like say your blood pressure goes high after you have your baby, or you have problems with urinary loss of urine after you have your baby that haven't improved or things like that. I think, in the long run, it can start to cause problems. We definitely are starting to see more women who have elevated blood pressure in pregnancy and afterwards that later on go on to develop chronic hypertension. So I think making sure you touch base with your physician after you have your baby to make sure no other issues have occurred, that is really important. A lot of women will suffer from postpartum depression and not realize that it's anything that's abnormal. I think every cultural has their we'll say stories or things that they say that say, oh no, that's just your hormones, or that's normal, or it'll pass. And a lot of women, it doesn't pass for. So I think I really do feel just strongly that it's important to come back for your postpartum visit. Sometimes women have complications in pregnancy where they should be counseled to wait a time period before they have their next child. And some pregnancy complications are so serious that we counsel you not to have any other children. But if you don't come back for your postpartum visit, I can tell you that in the hospital, but a lot of things are going on in the hospital. You have a brand new baby, you're trying to figure out breastfeeding, you haven't slept in a couple of days, a nurse is coming in every couple hours to check your blood pressure and wake you up and things like that. So I know how is when I'm on call for a couple of days straight and I don't get a good night's sleep. Sometimes some things don't stay in. So it really is important that you come back in so we can kind of go over, if I'm not the one that delivers you, what happened in your labor. Make sure you don't have any questions, because I can't tell you how many women I've seen that have some trauma because they had a hard delivery. And I don't meet them until their second or third pregnancy, and they are telling these stories. Well, if somebody would have sat down and kind of gone through it with them, they would have a better understanding of what happened. So that's kind of why I think it's important. And it's important to ask questions, because sometimes I feel like, and I'm guilty of this myself, I just say, okay, no, I don't have any questions. All right, thanks. But if there's something that's really kind of sticking with you, you want to ask so you can get the information to make sure you're well informed as well, because to be honest, you're going to be your best advocate. And I tell patients all the time, you're going to know yourself and your body better than somebody who sees you once a year or every 4 weeks. And so it really is important to come back in so we don't ignore things that we can maybe avoid future health. It's about preventative. I think America's really good at fixing problems when they occur, but we need to be better, from some of my experiences overseas, at fixing things before they occur to avoid them from even happening.
And Brian, I'm just going to chime in because those
Sure.
are great points, Dr. Outlaw, in that women, we do tend to get so busy that we take care of everybody else but ourselves. And making sure that we invest the time and reinvest the time to care for ourselves is important. But we also have to think about ourselves as ambassadors of information for our daughters, our friends, our aunts, our moms, because many of us are taking care of both ends of the spectrum with elderly parents and young kids. And so to learn to ask better questions is also an important aspect to apply, and then teach your family and friends to ask better questions, so that they are better informed and that they're better advocates for themselves.
That's a great point. Thank you, Dr. Walton. And thank you to everyone that has submitted questions today. We're going to close with one last question for both of our speakers. Possibly Dr. Walton, maybe you could start, and then Dr. Outlaw could follow. What would you say to someone who has put off seeing a woman's health provider due to the COVID-19 pandemic?
Sure. If they've been delaying their gynecologic visits because of COVID-19, we have a lot of other options now. We have, just like this platform, we have the ability to screen and ask some really good questions and get some hints at what's going on in terms of conditions. So if they are still concerned about a face-to-face visit, I would say take advantage of technology and do a telemedicine visit. It's not going to be an exam. It is just going to be a consultation, but it is worthwhile. And then moving forward, we are taking a lot of precautions to make sure we don't overbook our schedules, to make sure that we clean appropriately, and that many of us have been vaccinated, so it cuts down on our risk of being the transmitter of the virus themselves. And so if you're having an issue, please don't avoid it. And because other things are going to happen too, we want to make sure if you're having, cardiovascular issues, or if you're having lung issues, you need to see somebody for it. Don't wait until this is over. Get some help.
I think just to piggyback on that, when this all started last year about this time, none of us knew how long this was going to last. So, I think initially, yes, we were cutting back on even just well woman visits and not having as many patients coming in and spreading out visits. But when we started getting in the thick of things and realizing it was going to last longer, like Dr. Walton said, we had to start making some serious changes on how we saw patients and how we practice medicine. And I think the telemedicine visits, again, are a great option. But, a lot of places are screening you before you even get in the door. All the patients are uniformly getting questionnaires. Our office is doing temperature checks of all the patients when they walk in the door, as well as all of the providers and staff every day. We're doing thorough cleaning. So, the physician's office, I hate to say it, are probably safer now than what they were before the pandemic, just because of the fact that everybody's going that extra step to try to keep our patients safe, as well as keep the providers safe, as well as keep the staff safe. Because if we all get sick, there's going to be no one to see patients. So I wouldn't, I would recommend getting vaccinated, but that's my own, soapbox. But I also would recommend, if you have a problem, you can't avoid it. A lot of times if you come in to be seen in the clinic, it'll save you for an emergency room visit when things get so far past the point of return. So you really should use your primary care doctors, your cardiologist, your pulmonologist, your gynecologist, your urogynecologist, to make sure you're staying on top of your health care, because we might be dealing with this, we are dealing with this a lot longer than anticipated. And it doesn't seem like something that's going to ever maybe completely go away. So we need to make sure we continue to take care of ourselves and learn how to live with it like we would a lot of other infections and viruses that are out there.
Yeah, that's a great point. I think it's not something, it's something that's been with us for a while, and it's probably not going away. So if you have those health issues, it's really important to get those addressed. So thank you both again for using your expertise and teaching us a lot about women's health today. That pretty much wraps up our time. If you or someone you know and love would like to visit one of our practices, the contact information can be found on your screens. The recording of this webinar will be posted to our YouTube channel shortly and shared with all attendees via email. Thank you again for joining us today.